Welcome to this comprehensive clinical masterclass on the foundation of professional nursing. The nursing process. At its core, the nursing process is a systematic, problem-solving framework that directs clinical decision-making to ensure that every individual receives high-quality, standardized, and safe clinical care. Remember our golden rule. Right patient. Right care. Right time. As highlighted by our student and educator guides, professional nursing requires structure. A good nurse relies on the nursing process during every patient interaction, regardless of the clinical setting. It serves as an intellectual map, guiding our clinical reasoning, improving patient safety, reducing adverse events, and elevating professional practice. Let us examine the defining characteristics that make this framework so powerful. First, it is patient-centered, meaning the individual's needs, preferences, and clinical values drive every decision. Second, it is goal-oriented, providing a distinct target for clinical recovery. Third, it is systematic, structured in 5 sequential yet overlapping phases. Fourth, it is dynamic and fluid, constantly adjusting as the patient's physiological and psychological status evolves. Fifth, it is deeply interrelated, each phase directly feeds into and influences the next. Sixth, it is evidence-based, grounded in scientific research and proven clinical practice standards. Seventh, it is cyclical, continuously re-evaluating the patient until resolution is achieved. And finally, it is flexible, adaptable to acute care, community settings, and emergency interventions. Notice our first nursing pearl. The nursing process is cyclical and continuous. We care, we assess, we plan, we act, we evaluate, and then we do it again. Master this cycle, and you master the art and science of clinical nursing care. Step 1 of the nursing process is assessment. Assessment is defined as the deliberate and systematic collection of comprehensive clinical data about the patient. Without accurate assessment data, sound clinical judgment is impossible. Let us dissect the types of data we gather. First, we have subjective data, often called covert data. This is information expressed directly by the patient or caregiver that cannot be independently measured or verified by the clinician. It includes symptoms such as pain intensity, personal feelings, individual perceptions of illness, deep-seated health concerns, and past personal medical experiences. Next, we gather objective data, known as overt data. Objective data consists of observable, measurable, and quantifiable clinical parameters. This includes direct physical assessment findings like lung sound auscultation, vital signs such as blood pressure and heart rate, laboratory results like blood gas analysis or serum electrolytes, diagnostic imaging studies, and documented medical history. Now, where do we obtain this vital data? Primary sources include the patient directly, who remains the best source when conscious and reliable. Secondary sources are essential when the patient is incapacitated, young, or unable to communicate. These include family members or significant others, the formal electronic health record, physical examination findings, and laboratory or diagnostic test reports. To systematically collect this data, we utilize 6 established clinical methods. We conduct structured interviewing to obtain history, we maintain continuous clinical observation, we perform physical examinations using inspection, palpation, percussion, and auscultation, we perform rigorous chart reviews, we administer validated tools and standardized clinical rating scales, and we evaluate diagnostic laboratory studies. As our assessment pearl emphasizes, accurate assessment is the absolute foundation of safe, competent, and effective nursing care. Never rush your assessment, for an undetected clinical sign can compromise the entire plan of care. Moving to step 2. Nursing diagnosis. Once assessment data is gathered, the nurse must critically analyze, cluster, and interpret that data to identify actual or potential human health responses and clinical problems. It is critical to distinguish a nursing diagnosis from a medical diagnosis. A medical diagnosis identifies a disease state, whereas a nursing diagnosis identifies the patient's physical, emotional, and cellular response to that health condition. There are three primary types of nursing diagnoses. First, an actual diagnosis, which indicates that a problem currently exists in the patient at this moment. Second, a risk diagnosis, indicating that a clinical problem does not yet exist, but vulnerability factors are present, placing the patient at high risk for development. Third, the wellness diagnosis, which represents a patient's clinical readiness for enhanced health and positive health promotion. To construct a precise, standardized nursing diagnosis, we utilize the famous PES format. P stands for problem, the NUNDI diagnostic label describing the health state. E stands for etiology, the underlying physiological or environmental related factors driving the problem. And S stands for symptoms or defining characteristics, the subjective and objective clinical signs proving the diagnosis exists. Look closely at this clinical example. Ineffective airway clearance, which is the problem, related to excessive thick bronchial sputum, which is the etiology, as evidenced by persistent coughing, audible bibasilar crackles, and severe dyspnea, which are the defining characteristics. When formulating these diagnoses, always follow essential clinical guidelines. Base diagnoses strictly on accurate assessment data, prioritize life-threatening clinical issues first, state statements clearly and concisely, focus directly on the patient's human response, and strictly employ standardized NUNDI International approved diagnostic terminology. Remember the diagnosis pearl. A correct, precise nursing diagnosis leads directly to a targeted, highly effective clinical care plan. Step 3 of the nursing process brings us to planning. During the planning phase, the nurse synthesizes assessment data and diagnoses to establish patient-centered goals and formulate targeted, individualized clinical interventions. Planning consists of 3 essential steps: setting clinical priorities, defining measurable outcomes, and selecting appropriate nursing actions. First, when setting priorities, clinicians must establish order based on urgency and necessity. We rely heavily on Maslow's hierarchy of needs. Basic physiological survival needs, such as airway, breathing, circulation, oxygenation, and fluid balance, must always be addressed before higher-level needs. Once physiological stability is achieved, we address safety, followed by love and belonging, esteem, and finally self-actualization. Always address acute, life-threatening conditions immediately, while actively involving the patient and family in priority selection whenever feasible. Second, when establishing outcomes and goals, every goal must strictly follow the SMART framework. S stands for specific, defining exactly what outcome is expected. M stands for measurable, providing objective criteria to quantify progress. A stands for achievable, realistic given the patient's condition and resources. R stands for relevant, directly aligning with the clinical diagnosis. And T stands for time-bound, establishing a precise deadline for achievement. Third, when selecting clinical interventions, ensure that every chosen action is grounded in scientific evidence, falls safely within your professional scope of nursing practice, is culturally appropriate, remains patient-centered, and actively engages the patient in shared decision-making. Our planning pearl reminds us: good, structured planning today prevents severe clinical deterioration and complications tomorrow. Step 4 is implementation. Implementation is the action phase where the clinical care plan is actively executed into real-world practice. This is where theoretical strategy becomes hands-on patient care. Nursing interventions fall into 3 distinct functional categories. First, independent interventions. These are autonomous activities initiated directly by the registered nurse based on sound clinical judgment, without requiring a physician's prescription. Examples include patient repositioning, hygiene care, and bedside teaching. Second, dependent interventions. These are treatments prescribed directly by a licensed healthcare provider, such as administering prescription medications, ordering intravenous fluids, or dressing surgical wounds, which require a formal medical order. Third, interdependent or collaborative interventions. These are joint actions carried out in coordination with other members of the multidisciplinary healthcare team, such as physical therapists, clinical dietitians, or respiratory therapists. To safely carry out any nursing action, clinicians must strictly adhere to these 8 clinical execution steps. 1. Thoroughly prepare for the intervention and gather necessary equipment. 2. Verify the provider's order if applicable. 3. Positively identify the patient using at least 2 unique identifiers. 4. Explain the procedure thoroughly to the patient to gain consent and alleviate anxiety. 5. Ensure complete patient privacy and environmental safety. 6. Perform the intervention skillfully following infection control standards. 7. Document the intervention accurately in the health record. And 8. Immediately observe and evaluate the patient's initial response. As our implementation Pearl notes, safe, competent implementation turns a passive written plan into dynamic, life-saving action. Step 5 brings us to the final phase of the initial cycle. Evaluation. Evaluation is not simply the end of the nursing process, it is a continuous clinical review where the nurse determines whether patient goals were successfully achieved and if clinical outcomes were met. The primary purpose of evaluation is fourfold: to accurately measure patient progress, to identify which specific clinical outcomes were achieved, to critically modify or adapt the care plan based on actual progress, and to guarantee overall high-quality, safe nursing care. When evaluating a patient's response against our established SMART goals, the outcome will fall into one of 4 distinct clinical categories. Category 1. Goal met, meaning the desired patient outcome was fully achieved within the designated timeframe. Category 2. Progressing, indicating partial improvement where the patient is moving toward the goal but requires continued intervention. Category 3. Not met, meaning no observable improvement occurred, requiring detailed reassessment. And Category 4. Deteriorated, indicating that the patient's physiological or functional status has worsened, demanding urgent clinical reassessment and plan modification. The formal steps in evaluation require the nurse to compare current patient status directly against documented baseline goals, analyze objective and measurable data, engage the patient directly to understand their perspective, modify or completely rewrite the care plan as required, and seamlessly continue the nursing process cycle. Our evaluation Pearl reinforces this final truth. Evaluation is our compass, it tells us conclusively whether our nursing care truly made a positive difference in the patient's recovery. Now let us examine practical real-world applications across each phase. Look at these frequent under-eye diagnostic labels encountered in clinical practice. Ineffective tissue perfusion. Acute pain. Risk for infection. Impaired physical mobility. Deficient knowledge and anxiety. Notice how every label pinpointedly defines a specific nursing domain. Next, observe this concrete SMART goal example. Patient will verbalize decreased pain from 8 out of 10 down to 3 out of 10 within 30 minutes after receiving pain management intervention. Notice how this goal is specific to pain. Measurable on a numeric scale. Achievable. Relevant, and strictly time-bound to 30 minutes. Moving to nursing interventions, practical examples include continuous vital signs monitoring, administering prescribed analgesics, providing physical comfort measures, positioning the patient for optimal comfort and chest expansion, delivering patient education, promoting safe mobility, and maintaining an injury-free environment. Finally, observe the critical legal and professional mandate. Document everything. In nursing, the golden rule stands supreme. If it wasn't documented, it wasn't done. Every single stage must be thoroughly recorded in a medical chart, complete assessment findings, verified nursing diagnoses, detailed SMART goals, executed interventions, exact patient responses, and final evaluation outcomes. Accurate documentation guarantees continuity of care and legal protection. To synthesize our masterclass, look at the central cyclical diagram. The nursing process is never a linear, one-time event. It is a continuous, revolving loop. Assessment feeds into diagnosis. Diagnosis drives planning. Planning dictates implementation. Implementation leads to evaluation, and evaluation dynamically loops back into a fresh assessment. As our STAR guide emphasizes, always carry these core professional values into your clinical practice. Always use rigorous critical thinking. Remain fiercely patient-centered in every decision. Ground every action in high-quality evidence. Practice with genuine clinical compassion. And remain deeply reflective on your practice. As a patient's physiological condition changes, the cycle immediately repeats, adapting dynamically to ensure optimal outcomes, safety, and care quality. Thank you for participating in this RHW Visual Learning Series Masterclass. Master these 5 steps, embody critical thinking, and deliver exceptional care every single day.